One of the issues that I struggle with in my practice is this issue of duration of therapy. What we know about immunotherapy agents is in those patients that respond, they can often have durable responses that may actually go on beyond cessation of the immunotherapy. How often do you have to treat people in this particular setting? And then the issue of pseudo-progression, which I think is probably overplayed in lung cancer. But then the question I'll ask Dean about this is, treating beyond progression, and what are your thoughts about that? So we'll hear about that first, but I'm just kind of want to get people's thoughts about duration of therapy and is there a role for instance, with nivolumab, which, many of my patients are asking, why do I really have to come every 2 weeks, like forever if I'm responding? And that's a great question, but I don't know that we have any trials that are addressing these issues in the past. So treatment beyond progression?
Well, that's easier than how long we treat. So actually, we've struggled with this in terms of our studies. If we take a look at response, we're all using RECIST criteria for response, and it's 30% reduction in the sum of the diameters, and progression is 20% or more in terms of from the nadir. And so, in some patients in whom you have a profound, drop in your disease status or size, it doesn't take much to get to that 20%. RECIST criteria were not developed for this in terms of, duration of therapy. And in the renal cell study, in the NIVO study, it was actually examined patients who were treated with NIVO and then went and had progression based on strict RECIST criteria, and they were treated at least 6 weeks beyond that. And it's hard to do that type of analysis because you are selecting a subpopulation of patients. But what was interesting is that there were patients who went on and had a regression later on because their bump in disease size was really not that profound. We're really not talking about pseudo-progression. We're really talking about what I think are minor changes in total disease size, which may be clinically insignificant, but in terms of our clinical trials may represent progressive disease. We're seeing it the same thing in the bladder cancer studies. We've actually seen some late responses at 8 and 9 months in terms of stable disease that kind of fluctuated in between and could be interpreted as progressive disease. So I think that it's important not to withhold therapy too early, and that I think and that using strict RECIST criteria may not be in the best interest of every patient. On the other hand, I don't think that treating beyond clinical benefit is worthwhile, and so that's going to really need clinical judgment.
And so Jared, I think this is it's a huge issue in lung cancer where
For sure.
I think many times I get calls about community oncologists wanting to kind of hang on to the immunotherapy even though there may be progression, thinking that it's pseudo-progression. But at least my read of the data, it's more often progression than not. What are your thoughts about pseudo-progression, specifically in lung cancer?
So I think we see 3 major categories of apparent progression in lung cancer. So I think the thing being discussed most often at the podium is this phenomenon of pseudoprogression, the idea that the cancer appears to be growing and then later wonderful things happen. This is much, much less common in lung or head and neck cancer than it is in melanoma. The vast majority of a clear apparent progression up front is real in lung and head and neck cancer. Second, pattern that we might see as mixed progression. So you have a patient on trial, and this actually isn't new to us, right? We know this from the EGFR story, we know this from the ALK story, that you can have some lesions that are responding very nicely while others can be growing. And there, in the real world, we apply clinical judgment, right? So if we have a central growing lung nodule that's pressing on a major airway, pressing on a major vessel, where that's really threatening to hurt the person, of course you have to switch, right? You don't just keep going with that. Where if you have a small peripheral nodule that doesn't have a lot of threat, you might keep going. And I think that pattern, that need to apply clinical judgment, very much applies to the PD-1 and PD-L1 inhibitors, where on the trials and now in clinical experience, we're certainly seeing that pattern of mixed progression more often, and there are systems for trials that allow you to account for that. The final pattern, and we can't ignore that this happens, is progression. drug simply is not working. And that needs to be acknowledged, that quite a large amount of apparent progression is in fact real in lung cancer.
Back to you, John, this issue of duration. I'm very tempted in my practice to give people breaks because they've had a nice response. They may not need it as frequently. I don't know that any trials are addressing that issue. Certainly in lung, the paradigm of kind of like 4 cycles, so-called induction therapy, and then a maintenance strategy is very appealing because we do it in lots of situations. So your thoughts on that?
Yeah, I mean, I think you're raising a question that's even more of a question than with chemotherapy. So I don't think we really think of maintenance chemotherapy like pemetrexed, for example, as having residual benefit after you stop. But we know for immunotherapy, we're inducing the adaptive immune system, and those T cells don't disappear. They hang around. And so it is quite possible that we're going to be over-treating by treating for years, or you may be able to give a break, and then if it wakes up, you can start treatment again. So I'll give you an example from a patient of mine. And he's described his story in some newspaper articles in the Houston Chronicle and elsewhere. So he's happy about his story being told. He was a gentleman I treated in the Keynote-001 study with pembrolizumab. And he had metastatic squamous cell cancer. And, he had been told previously to work out his affairs and, get things in order, because with metastatic squamous cancer, after he'd had first-line chemotherapy, he should expect a median survival of 3 to 6 months, which was not inaccurate at the time. And so he went on this study, and his tumors slowly grew, shrunk and shrunk and shrunk. He's an engineer. He actually was involved in the Navy, and so he would track quantitatively every single lesion and the volume and so forth. And after 2 years, they had just gotten down to little tiny residual things. And he said, do I have to continue this? So the Keynote-001 study let you stop after 2 years. It gave the option. But when you talk to people from the company and investigators, they said, well, we didn't think that was something that was really going to be happening. We just sort of put that in there. And it is happening. So after 2 years, we said, well, you've got a couple little lesions. Why don't we just radiate them and see what happens? And he just got back from so that's what we did a number of months ago. He just got back from a trip from Hawaii, and he stops in and sees us and gets his scans, and then just goes about his business now. He's not getting any active treatment, and he's now coming up on 4 or 5 years after he started his treatment overall.
Yeah, this is exactly the type of patient that raises this issue, and I think that at some point we have to deal with the duration of therapy question.
Well, we've actually had a lot of experience with IL-2 patients in the past, and there's never been a very strong correlation with the total number of doses and the response. And I recall a few patients that I had that, they get 1 or 2 doses and said, this is not for me. And they've gone on and done really, really well.
Yeah.
So I think the concept with the immune system is that if you're going to get a response, you may get it regardless of how many doses we give. And so I think this is why finding a biomarker, particularly predictive biomarkers, or a way to measure response is going to be really important. One of the things that we've been using quite a bit has been PET scanning. And what we'll often see, at least in the melanoma population, is the PETs will begin to decrease the hypermetabolism long before the CAT scan will clear. And we're finding this particularly useful in those kind of equivocal cases where we're not really sure whether we might be dealing with a pseudoprogression or a real progression.
So